Okay, hello, I'm back.
Okay, shall we start, Doctor?
Yeah, can.
Okay. Good afternoon, everyone. Welcome to the week one.
Priscilla, I think, yeah.
Yes.
No, your mic muted.
Muted.
Okay, can already.
Can you hear me?
Can hear you.
Okay. Our speaker for today is Dr. Siti Nurbaya, geriatrician from Hospital Pakar, University Science Malaysia, and our chairperson is Dr. Alan, consultant geriatrician from Hospital Seberang Jaya. A little bit about Dr. Alan. He is our he graduated from USM in the year 2003 and completed his MNet from University of Malaya in 2011 and a fellowship in geriatric medicine under Ministry of Health in 2016. He's also a current president of Malaysian Society of Geriatric Medicine, MSGM Malaysia. He's actively involved in clinical research and have published many journals locally and internationally. Has contributed many as an expert panelist in authorizing clinical practice guideline, and he's also involved in management of osteoporosis as an expert panelist in CPG guideline, third edition. Without further ado, let's welcome Dr. Alan.
Thank you very much, Priscilla, and welcome everybody. It is my pleasure to introduce our distinguished speaker, Dr. Siti Nurbaya Muhammad Nawi. Dr. Siti is a highly accomplished geriatrician and a medical lecturer at HUSM. She completed her MBBS at the University of Adelaide, followed by basic physician and subspecialty training in geriatric medicine in South Australia, and was awarded fellowship of the Royal Australasian College of Physicians in 2018. In her current role, she coordinates geriatric medicine services, leads the fracture liaison service, and serves as an EXCO member of the Malaysian Society of Geriatric Medicine and Fragility Fracture Network of Malaysia. Her professional interests include frailty, sarcopenia, osteoporosis, and geriatric rehab. Please join me in welcoming Dr. Siti Nurbaya.
Thank you, Dr. Alan, for your kind introduction. My name is Dr. Siti Nurbaya. I'm a geriatrician. And first of all, I would like to thank the College of Physicians for the opportunity for me to share, a topic for my talk today. And as the first speaker for the geriatric webinar for this month. Okay, so the topic that was suggested to me was initially whether, sarcopenia, frailty, which is quite sort of the in thing at the moment in geriatrics, it is quite a heavy topic, a lot of technicalities in there, but I hope probably I can like some light of the concept, and for those who are not really aware or familiar with the term sarcopenia. Okay, so I shall move on with the slide. Okay, so I'm so sorry. I think it's supposed to be a video, but it's not. This video should be like a walking, person in these muscles and all that. So what I want to highlight here is that if we can look at our body, it's just full of muscles. A lot of function in our bodies are, run by muscular movement. However, we find that we have a research, significant research in cardiology, the heart, looking at specific organs, but somehow muscle probably gets the least attention with regards to in our medical field these days. Okay, so some overview of sarcopenia. All right, so historically, the term was coined in 1989 by Erwin Rosenberg. The origin of it, the word sarx in Greek means muscle, and the penia means loss. So loss of muscle. And so Dr. Rosenberg is actually a professor in nutrition. And in 1988, they have a convention that he attended, and his, this is his words. I noted then that no decline with age is as dramatic or potentially more significant than the decline in lean body mass. And there may be no single feature of age-related decline more striking than the decline in lean body mass in affecting ambulation, mobility, energy intake, overall nutrient intake and status, and independence and breathing. So that was, what he observed then. Okay, so it shows that, muscle actually involve the whole body, outside and even inside, the function of respiratory system, cardiac function is actually involved muscular function. And hence, and with aging, they have noticed that, there's this progressive decline with age. And that's how the term sarcopenia come into a sort of the research field and now in the medical field as well. And sarcopenia is also now recognized as one of the geriatric syndromes. So if you want to, this is the cross-section of a thigh. Okay, so if we look at the left-hand side, we can see a nice, healthy muscle there, with minimal adiposity and area. And if we look at the sarcopenic muscle, we can see the muscles have shrunken, and there's loss of muscle mass there. All right, so now I'm going to the technicality of it. So definition of sarcopenia, does it mean just, having low muscle mass is, considered sarcopenia? Okay, so we have a few working groups of sarcopenia, and they have defined, generally, they come up with different criteria, but essentially almost all working groups have agreed that definition of sarcopenia means there's age-related loss of muscle mass, plus, so it has to be accompanied by low muscle strength and also or low physical performance. This is according to the Asian Working Group for Sarcopenia. And sarcopenia is also defined, so according to the European group, so European Working Group for Sarcopenia, is defined by low level of measures for three parameters. Again, it's muscle strength, muscle quantity, so equivalent to the muscle mass, and physical performance as an indicator of severity. So we must fulfill this definition of when there's low muscle mass and also there's low muscle strength and or function. Okay. And what about the epidemiology of sarcopenia? Sarcopenia prevalence varies widely depending on the criteria used and was estimated to be around 10 to 16% of the elderly worldwide. This is from a systematic review done by Yuan et al. In 2023. And according to the review of epidemiology studies from Asian countries that use Asian group criteria discovered that the prevalence of sarcopenia ranged from 5.5 to 25.7%. And it is associated with poor health. It increases the risk for falls and fracture, impaired mobility, functional decline, prolonged hospital stay, poor quality of life, and even mortality. And what are the risk factors for sarcopenia? So older age definitely is one of the risk factors. Lifestyle, physical inactivity or sedentary lifestyle, socioeconomic status, poor nutrition, alcohol, metabolic conditions such as diabetes, hypertension, dyslipidemia, and also medication are some of the risk factors that predispose somebody to have sarcopenia. So I'm not going to go into details of the pathophysiology of sarcopenia as such, but what I want to illustrate here is that the pathophysiology and the mechanism of sarcopenia involves many facets of our bodily function. Okay, at cellular level, the lifestyle, the neural function, malnutrition, all this actually contributes to the sarcopenia in a person. Mitochondrial dysfunction, the hormonal changes that happen as we age, and so all this causing the sarcopenia as an end result. And how do we diagnose, somebody to have sarcopenia? Okay, so if we look at the diagnosis of sarcopenia, so again, if we go back to the definition, we have to remember that we need to, have somebody that have a low muscle function, low muscle mass, and also low muscle function. Okay, so how do we measure these two components? So with the muscle mass, there are a few modalities that we can use to measure. For example, DEXA scan, like the dual absorptiometry machine, that can measure all the appendicular muscles and other body components. CT scan also can be used to measure the muscle mass. MRI, again, can be used, and also BIA, bioimpedance absorptiometry. So these are the modalities that potentially can be used to measure muscle mass. And what about to measure muscle strength? Muscle strength, we can use the hand dynamometer. So of course, at the moment, if we look at in the market, there are various types of hand dynamometer. But if we're talking about, say, research level, the recommendation usually to use a specific type, which is JAMA dynamometer. And there's another brand which slipped off my mind at the moment. But yeah, so we use the hand dynamometer to measure the hand grip strength. The other parameter that can also be used to substitute the hand grip strength is gait speed of a person. So we measure how fast they walk, and we see how far they can walk in per second. Okay, so as I mentioned earlier, there are different groups of, working group for sarcopenia. And, we have the EWG-SOP, which is a European group. Okay, we also have the IWGS, which is the International Working Group on Sarcopenia. We also have AWGS, which is the Asian Working Group for Sarcopenia, and the FNIH, which is the Foundation of National Institute of Health. And we can see they have a variable cutoff for muscle mass and also muscle strength for each of this working group. And why, the reason for this difference is that, of course, when they come up with these criteria, how they validate and all that, the population that they first come up, this criteria with, are different. Okay, so European, they will do European group, Asian group. Hence, the variability of the muscle mass and also muscle strength. Okay, so just now, I introduce you all to the different groups, working groups for sarcopenia. And there's also screening tests for sarcopenia, meaning that, before we subject a patient to go for DEXA scan and all that, there's also recommendation for screening, for sarcopenia first, meaning we try to find out or identify people who are at risk to have sarcopenia. And again, screening tools, so we have various, screening tools for sarcopenia. But what I put here is, some of the, that has been, that has come up in sort of research and all that. Okay, so SARC-F is the one that is very famous at the moment, where, a lot of guideline has recommended to use SARC-F as a screening tool. So it's a questionnaire base that can be answered by the person or the patient. Okay, we also have the MSRA, but again, MSRA is used less in practice. And we also have SARC-CALF, SARC-F that is combined with calf circumference to come up with a score to see what's their risk to develop sarcopenia. And there are also other, scoring like prediction equation, using anthropometric measurement. There's also, study that, try to sort of screen by using physical performance. But later I will highlight, the common ones that have been used or recommended by guidelines. Okay. So this is the SARC-F questionnaire that I was talking earlier. Okay, so SARC-F essentially represents the component of the questionnaire. If you can see, the first question is strength. Number 2 is assistance in walking. So for the strength, the question that we ask is how much difficulty do you have in lifting and carrying 10 pounds? So usually 10 pounds because in Malaysia, we don't really use pounds. So it's like, 2 bags of rice. Okay. And so if they don't have any problems, you put score 0. But if they say, oh, there's some difficulty, you put 1. Or if they are not able to, scoring 2. And the next question is assistance in walking. How much difficulty do you have walking across the room? So similarly, none, some, and a lot, or if they're not able to, they would score higher. Rise from the chair. How much difficulty do you have transferring from a chair or bed? Again, the scoring 0 to 2. Climbing stairs. How much difficulty do you have climbing a flight of 10 stairs? And lastly, we ask about, how many times have you fallen in the past year? And we score them accordingly. So if they score 4 or more, that indicates positive risk for having sarcopenia. Okay. So again, if you remember, this is a screening. Okay, so it's not quite, if they have score of 4, it doesn't mean that they automatically, we label them as having sarcopenia. No. Okay. So I just going to show, what are the recommendations regarding screening of the currently available guidelines at the moment. Okay, so if we look at the European Working Group for Sarcopenia, okay, so how do we, first they start with case finding, all right? So case finding, either, you can do like a screening, we just ask, elderly to do the SARC-F questionnaire, or if there's any clinical suspicion, such as, somebody has been falling quite a lot, or somebody has, been more dependent before they can walk independently and now needing help, with walking frame, for example. Okay, so that's how we identify the people that you want to do this questionnaire. And then you assess for the muscle strength, using the dynamometer. Or if they cannot do that, we can do the chair stand test, which is, we're asking them to stand up and sitting and stand up for 5 times. And then we time them. Okay, so if they have impairment in this either muscle strength or the chest stand test, so this means that they may have probable sarcopenia. Okay, so according to the algorithm, okay, if we look at the, once they have sarcopenia probable, by right, according to this guideline, we should actually send them for confirmatory tests, with DEXA scan or BIA, CT, and so on. Okay, and then once we confirm the low muscle mass, and then we want to decide how severe is the sarcopenia. Okay, however, realistically, if we think about it, how many places that have access to DEXA scan, CT, and BIA? So hence that's why even after the probable sarcopenia, if the patient is we looked at clinically the patient is really at risk, in clinical practice, this is probably enough. Having probable sarcopenia probably enough to trigger assessment of the secondary causes and also start intervention early. Okay. So this is according to the European group. And what about the Asian group? Okay, so the Asian Working Group for Sarcopenia, which was published in 2019. Okay, so they have come up with, sort of different settings. Okay, so if we look at on the left-hand side, we have the primary healthcare, like community clinics, for example. Okay, so again, with the case finding, they recommend to use SARC-F also, or even SARC-CALF. We can do that. And from there, we can see if from the scoring from SARC-F or SARC-CALF, okay, if the score is positive, and then we proceed with checking the muscle strength or the physical performance. And again, if they have low of these 2 performance, then possibly they have sarcopenia. Okay, so again, in primary healthcare setting, from possible sarcopenia, lifestyle modification and diet and exercise can already be instated at that point. Okay, but however, if there are, other conditions that we think that we probably want to confirm the diagnosis, or whether we are concerned of, other causes that may have caused this, especially in the acute sarcopenia setting, that we think, oh, this is very quick, or whether it can be due to something else. And then of course it's encouraged for them to be referred to tertiary setting where confirmatory and all that, and further assessment to be done to confirm the diagnosis. And for the international ICSFR, International Conference on Sarcopenia and Frailty Research, again, the approach for this international conference is that they suggest to screen everyone, okay, not just somebody who has fall and all that, anyone who is 65 years old and older, or 60 years old, according to the the area, how they characterize their older people. Okay, so older adults aged 65 years and older should be screened for sarcopenia annually, okay? Or after the occurrence of major health events. For example, if they just had hospital admission, or they had a fall that requires surgery, or for example, okay? So any major health events, so they suggest to actually screen for sarcopenia. And for this international conference, they suggested that screening for sarcopenia can be performed using gait speed, or with SARC-F. So for now, it looks like quite uniformly, every guidelines sort of use SARC-F as a screening tool. Okay, and for ICSFR, individuals screened as positive for sarcopenia should be referred for further assessment to confirm. So for them, confirmatory is mandatory. Okay. Okay, so I know the three, it's more like a international, European and, international and all that. But what about, because we don't have one in Malaysia just yet, okay? So the closest we have to home is probably Singapore, okay? So what does Singapore do for their sarcopenia? Again, they recommend case finding according to specific high-risk population, okay? So that, people who have recurrent falls, patient who, to have osteoporosis, that has higher risk to get sarcopenia. And again, use SARC-F, cuff circumference, or SARC-CUF. And individuals screened as positive should be evaluated for possible sarcopenia, and look for the reversible causes, and to instate straight away the intervention for the sarcopenia itself. Okay. And as for the diagnosis for Singapore, because if we look at the international recommendation, okay, there's as long as we, use any of the working groups, as long as it's validated, we can use any of this working group definition to diagnose sarcopenia. But of course, for the Singapore, they recommend using the Asian working groups because of the cutoff level for muscle mass, and also for muscles and the muscle strength would probably, the closest for the Asian population. And they also, suggest to use, for hand dynamometer, to use whether JAMA or Smedley hand dynamometers. And also, okay, so when it's necessary to determine low mass, they also recommend the use of DEXA other than the other imaging modalities. Okay, so I know it's quite a lot to actually take on, but okay, but I think as for now, what we have to remember is that for sarcopenia, there's low muscle mass and low muscle strength. Okay. And the low muscle function or performance is, indicates the severity. So if a person has all three, so that means they are like very severely sarcopenic. So meaning they have low muscle mass, if they have low muscle strength, and also low performance, then again, that means that they are very sarcopenic. Okay, so treatment of sarcopenia. Okay, but so treatment of sarcopenia, at the moment, generally all working groups recommend sufficient caloric and protein intake and resistance exercise as treatment for sarcopenia. Okay, and okay, so for the nutritional supplement, okay, is the protein. Okay, so clinicians should consider protein supplementation and a protein-rich diet for older adults with sarcopenia. And it's both, okay, protein and also caloric, right? And also it should be supplemented with resistance-based training. Okay, so when we say resistance-based, so meaning it has to, to work the muscle, to give some resistance to the muscle to improve the lean mass and also to improve the strength. Okay. And as for the international group, at the moment, vitamin D, there's no sufficient evidence to recommend. But definitely they don't recommend any of the pharmacological treatment at the moment because everything is still in the pipeline. There's still a lot of research going on. So there's no strong evidence to suggest any of the pharmacological treatment. Okay. As for the Singapore, also similar, older person with sarcopenia should be encouraged to participate in resistance-based exercise to improve their muscle strength and physical performance. And clinicians should advise older person with sarcopenia on the importance of the quality diet. Because if we actually look at the diet of our older people these days, we have to look, their dietary intake is probably not sufficient and not enough as according to the recommended daily intake. A lot of factors, sometimes because of ill-fitting dentures, or they don't have, or they just eat gentleless, and, reduced appetite and other factors may have contributed to the poor oral intake. Okay, so this should be emphasized in the treatment for sarcopenia. And nutritional intervention should be combined with physical exercise because if just one thing alone, without, if we want to increase the muscle bulk, but without the physical activity, we won't get that increase of muscle mass as we hope for. So that's why it should go hand in hand, the dietary nutritional supplementation and the physical exercise. And as for the Singapore, clinicians should consider vitamin D supplementation for sarcopenic older people who has low vitamin D level. So it's a conditional recommendation with regards to vitamin D. And as for prevention, we should always, advise regular physical activity among our older people, and also emphasizing on the resistance-based exercise. So although, say our patients, they go for walks, for example, or I like to go walks, brisk walking, jogging, and all that. But always remember to advise them to actually include, at least twice a week of resistance type exercise to improve the balance and also the strength of their lower limbs. And older adults should be encouraged to have adequate protein intake of at least 1 gram per kilogram body weight per day to prevent sarcopenia. So probably it's hard for our patient to actually weigh, what's the protein, but probably can give recommendation of, what is this much of protein that they can eat, for example. And I find that, working together with our allied health professionals, the dietitian is very useful. And they also can give the guidance of dietary intake to our patient. Okay, so again, as for pharmacotherapy, at the moment, it's not recommended. Okay, there are medication that is under development, such as growth hormone, antibodies to myostatin receptor, activin 2B receptor inhibitor that has been shown to increase muscle mass. However, this increase of muscle mass has not been shown to give a meaningful improvement to muscle function as such. Hence, that's why at the moment, there's nothing that can be recommended as pharmacotherapy. Okay. And like I said earlier, the vitamin D supplementation, again, is variable. Some group recommend and some group yes, but I think at the moment, if somebody who has low vitamin D, after checking the level, it's probably worth to supplement the vitamin D. Okay, so sorry, I'm quite early here, half an hour. Okay, but so the take-home message from my talk today is sarcopenia is an important geriatric syndrome that can affect the functions and quality of life of an older person. The challenge that we have at the moment is the difference in diagnostic criteria and cut-off variability of the diagnostic criteria according to different groups and different population. And these are giving the challenges to have a standardized identification of this condition. So with regard to current practice, at the moment, Malaysia, we don't have specific guidelines or clinic CPG for sarcopenia. But at the moment, it's probably something that we can start, being aware of it, and maybe we probably has to start, adopting some of the pre-existing guidelines to match our population. And also we should also, again, exercise pragmatic approach because, realistically, definitely, not all places have the access to DEXA and all that. But we do have that sort of clinical guideline, for, somebody that we suspect to have sarcopenia, probable sarcopenia or possible sarcopenia. And so for the current recommended therapy, is still nutritional supplementation and resistance exercise. And of course, more research is needed in this field. And of course, like local research is, needed, so that we can have, more, so that we can know, if we do this, what is the objective outcomes that, we want to see, whether we are looking at a specific muscle mass increase, or, we can also look at, different outcomes like clinically meaningful outcomes, quality of life and such. And, the more research and the more data we have in our own population will help us even better to actually come up with our own practice and local guidelines. So with that, I think that's the end of my slide. And thank you. So that's my email. If you want to email me any questions or you want to ask anything, you can contact me on that email. Thank you. Back to you, Dr. Allen.
Thanks very much, Associate Prof. Dr. Siti. So there are several questions I can see. One from a family physician from JB, Dr. Law Teck Yong, and also Richard Teo. Actually, they are the same questions. Is age, is it a must inside the definition of sarcopenia? What about younger people? Can they still have sarcopenia? I think this question is they need clarification regarding the primary sarcopenia and secondary. So, Dr. Siti, what's your take on that?
Sorry, the question, Dr. Allen?
Sorry, did you hear the...
Can you hear me?
Yeah, can you hear me?
Okay. So the question earlier was, is age a requirement for them to have sarcopenia? Okay, age-related must be definition of sarcopenia. Okay, all right. So, so I guess, yeah, true. So the question, yeah, like what Dr. Allen has said, also, whether it's primary or secondary. Okay, so if just, an older person found to have sarcopenia, and, as we have to do workup to look for the secondary causes. Okay, so if we, unable to find any other significant causes that may have contributed to the sarcopenia, like say a very bad kidney disease, for example, some thyroid disorders, for example. So we can say that this is like most likely to be primary sarcopenia, which is age-related. Yeah, so I hope that answered that question from Dr. Teck.
There's one question from Prof. Tan, one of the prominent geriatricians in the country. Many patients tell me that their kidney doctor told them not to eat too much protein. How should we respond?
Okay. So first of all, sometimes it's very easy, even us, in medical, sometimes we easy to label, oh, this patient is CKD, that, they're not supposed to eat protein. And actually a lot of CKD patients actually do some Google reading also, that they can't eat too much protein. Okay, so I guess, actually, only the advanced level CKD, like stage 4, stage 5, yes, we understand that, there needs to be limitation of that, protein. However, CKD 3, we should actually regard it as a, like a normal population. But again, if we are concerned, and again, I think, again, for this, when they have advanced CKD, then it's considered like a secondary sarcopenia. And I find that I like to work hand in hand also with the nephrologist and also a specific dietitian for a CKD patient, that, how can we do with regards to our CKD patient who is having malnutrition due to their CKD. Yeah. So I don't know, Prof. Tan, you probably.
Okay. So there's a pros and cons. You want to reduce the renal hypertension by restricting protein, and at the same time that is the cause of the sarcopenia. So at some point you may need a supplementation like ketosterol to supplement the amino acids once you start restricting the protein. There's one question on calcium. The question is, since you have mentioned vitamin D, what about calcium? Is it equally important? And how much is it adequate?
Okay, so I think if we look at the recommended daily intake, we need about 1,200 milligrams of daily calcium. So again, so by right, whenever we have a patient, we should actually get a history from them, their dietary history of how much dairy product they are taking. Okay. So vitamin D, so of course, vitamin D, just now we are talking about sarcopenia for the muscle, but of course, calcium is needed for the bone. So, because somehow, because just now we were talking about the muscle only, but always remember bone and muscle, they're also cross-linked as well with regards to function. So if we talk about vitamin D, calcium also is important for the prevention of osteoporosis as such. So with calcium, I think we have to assess if the person has, adequate daily intake from their dietary. But I have to say, a lot of our patients, especially in Malaysia, we don't take dairy, from if I ask most of my geriatric patients, they grew up not drinking milk and all that. So it's very different from European population or Caucasian. So if they have enough dietary intake of calcium, yes, that's fine. But the recommended daily intake is a 1,200 milligram of elemental calcium. So if we want to just see if they have reached that, and refer to the daily recommended intake for calcium.
Yeah. So this 1,200 includes their dietary calcium intake as well. So we don't really need to supplement the full calcium, right?
No, yeah, true.
Yeah.
So if they have
Otherwise,
enough, they drink, they eat cheese, definitely drink this much and will complete that recommended already. So there's no need to supplement with that. Yeah.
even the supplements also, different formulation has different elemental calcium
Correct.
content. And out of that, maybe like 30% is absorbed. The absorption rate also is actually very little.
True.
Yeah. There's one question on HMB supplementation. Is there clear evidence for HMB supplementation together with protein?
Okay. Okay, so I probably need your help also, Dr. Allen, from your experience, but okay, but for HMB, I think there's sort of a variability in evidence. Some, if you look at the sort of Asian group of working group for sarcopenia, they do say there's some evidence to say that HMB is helpful, but other papers doesn't really, show that HMB in particular would help with that. But I don't know, what do you think, Dr. Allen, in your practice? Because I can't find a strong evidence to say HMB per se actually helps, particularly to help with sarcopenia.
Okay, so this HMB, it actually is like anti-inflammatory that prevents muscle loss. There are actually evidence on hospitalized older people. So they randomize into a group taking HMB and without taking HMB. So both groups actually have muscle loss, but the group taking HMB has slower or less muscle loss compared to them. So there's some evidence for it as well. Anyway, if you look at the American College of Sports Medicine, HMB supplementation is also inside their recommendation. Like people going for marathons, they also take. So to me, I think in terms of the risk, not that much, except for the pocket lah.
Yeah.
And then the benefit, there is some evidence.
Yeah, yeah. Okay, and I can see there's question there also, the difference between cachexia and sarcopenia. Also, is sarcopenia considered a natural aging process or more of a disease? Okay, so cachexia, generally when we say cachexia, we're referring to, actually, I think phenotypically, they are almost the same, isn't it? You're losing muscle, okay? But when we say cachexia, we are referring to more of a, inflammatory secondary causes, people with cancers, people with, particularly cancers. And that somehow like differentiate the two conditions between cachexia and sarcopenia. But essentially the two of them definitely they both are losing muscle mass, okay, but I think like the etiology that would be the differentiating part. Also sarcopenia considered a natural aging process or more of a disease, okay. So it has been, well, I guess we have although it can happen with aging, it's the same thing like osteoporosis. Okay, so of course, as we age, we lose bones and all that, but it doesn't mean that it's not preventable. Okay, so by knowing that our muscle mass can, be lost as we age, meaning that we, have more, we can have more time to prepare, and to prevent that from happening. So it is preventable. It can be, it's part of aging, but it doesn't mean that everybody has to have that. Similarly, like dementia, okay, it's common to have dementia, as we get older, the older person will have higher risk, but doesn't mean that it's not preventable. Okay.
So probably one is a pathology, the other one is a degenerative, and which is reversible. Yeah. I think cachexia, the pathology is different. It's due to cachesin. So however you treat, the patient will keep losing muscle. There's one question from Dr. Harif, probably a FMS, I think, family physician. Any gold standard for workup on sarcopenia in a clinic kesihatan setting? Even older person comes to you, what are the simple way to approach it?
Okay. So I find that, after, when we look at the some of the recommended algorithm, okay, so I think it's quite something that's quite easy to do is actually we can do the SARC-F is actually very easy to do. SARC-F is that, that 5 questions, but of course you need to sort of translate to Malay or Chinese, depending on the patient. But the Asian group does recommend using SARC-F. If you look at the Singapore also start with SARC-F. Yeah, so SARC-F is quite easy to do. It won't take long. And I mean, it's not that sensitive because with SARC-F, actually sensitivity is about 15 to 30%, but it is very specific. So it has about 97% of specificity with regards to SARC-F. Okay, so SARC-F is something easy to do, and if we have a hand dynamometer, is if we can get one in clinic, because it's not that expensive. It's not like having a DEXA scan that kind of costs like hundreds of thousands. Okay, so if applying these two things is something that is probably feasible to do it in KK setting. Okay, and together we try to look for secondary causes, and and I think we can start the treatment and intervention at that point at clinic kesihatan level if we cannot find any secondary causes. So I think SARC-F is probably the easiest way to start.
So I think it's like they say that if you cannot measure it, you cannot improve it. So it's an objective way to measure and monitor should be useful, right? We always do echo to look at the heart EF, although clinically we can even detect the heart failure, but we still need to know how much so that we can try to improve it. There's one question. Okay, this is a very specific question. Once sarcopenia is diagnosed and treatment mainly is nutrition and exercise, so do they need to be managed by a geriatrician or a general physician will do? And do we need to repeat any imaging test to monitor the response to treatment? And how frequent do we repeat?
this is, it's very specific. And I have to say it's difficult to answer. It's difficult to answer because we don't have much access to the modality to measure one. And we also haven't got, the sort of proper local guidelines too. And, because we have to weigh the, benefit, financially, how much, if we were to send patient, how much patient going to pay, that kind of thing. So at the moment, I find it, I don't know the answer to this actually at the moment, but I think if there are, other geriatric syndromes and all that, it's quite fair to refer to a geriatrician because it is part of a geriatric syndrome with regards to sarcopenia.
Yeah, I think there's no specific guidelines. But actually, as a patient, if we have an objective assessment to pinpoint, for example, let's say your blood pressure or cholesterol, once you see that what is so high, then you'll be more motivated to try to exercise and change your lifestyle, sedentary lifestyle, like that. So I think it's the same with the sarcopenia. The objective measurement of that can be helpful to motivate them. There's one question on the vitamin D combination with calcium. So is it adequate or do we need a single vitamin D supplement? I think this depends on the vitamin level, whether it's normal level, then you go for the maintenance dose, 800 international unit per day. But if it's a deficiency or insufficiency, then you definitely need to treat it first with a high dose. For example, like 50,000 units once a week, for 8 weeks. And then after that, once it's normalized, then only we go for the maintenance. So whether the single combination is adequate or not, you need to look at the formulation, the brand, how much. Because in the market, there are so many types of vitamin D3 together with calcium. So you need to look at the content of that.
As for supplementation, we should, everybody with normal renal function should get vitamin D3, which is the cholecalciferol. The calcitriol, we try our best to reserve only for CKD patient because that is actually activated vitamin D. Or with calcium plus vitamin D. Okay, so I think we have to look at the specific content because in a day we need at least 800 to 1,000 international unit of vitamin D. That's for the maintenance dose. And in a day, just now, like we said, it's at 1,200 milligrams of elemental calcium. So so we have to look at specifically of particular product of how much in each tablet. And then we have to see whether, it would be enough for the 24, for a daily recommended dose for the two. Yeah.
So those CKD stage 3B and above, you need the activated type. It's either calcitriol or alpha calcitriol because they wouldn't be able to activate. So, okay. In what kind of patient would you do DEXA to confirm the diagnosis of sarcopenia?
Sorry, where's the question? I cannot see. Hang on. Okay, in what kind of patient we do DEXA to confirm diagnosis of sarcopenia? Okay, so actually, if we have access, if we suspect sarcopenia, I think we should all do the DEXA to confirm the low muscle mass. So in anyone, if you have access to that, anyone that we, say the one that we screened earlier, that we think that's high risk, and then we should send them for a confirmation with the DEXA scan for the diagnosis of sarcopenia to quantify that low muscle mass. Okay.
Next question. Older population may have a lot of comorbidities. So supplying them with supplements like calcium, vitamin D may contribute to polypharmacies. What is your take on this?
Okay. So again, I think in anything that we give, we have to look at indication. Okay. So if the indication is there, then we should give to the patient, isn't it? That's my take lah. So if there's no indication, of course we don't give. But if somebody who has very bad osteoporosis, hip fracture, they definitely will need that calcium vitamin D. Yeah. Because I find that maybe we feel that it's polypharmacy because because we are adding medication. But definitely when there is clinical indication for that, I think we still should give it to them. But take that opportunity also to review other medication, because there are times that the other medication has been there for so long and never been reviewed. Yeah, so let's take that opportunity also to review other medication as well, whether the indication is still there and whether it's still valid. Okay. Oh, Dr. Ellen, I think you're muted. Okay.
What is your opinion regarding the screening for androgen deficiency, low testosterone, especially in guys? And do you recommend treating it if that's low?
Okay. Generally, I would go clinically. Okay, because usually, let's say if I see a man, usually in my practice, mainly osteoporosis. If we see osteoporosis in men, if they clinically, if they have some signs of hypogonadism, for example, then that's when we do the screening. However, if with regards to sarcopenia, would I still feel that if I cannot find other causes that may have contributed to that, it's something that I probably would consider if they are quite youngish, so sort of not that old and just reach 60 years old or something like that for men. So it's probably somebody that we would want to consider checking and treat if it's low. But of course, again, this kind of hormonal therapy and all that, generally we would work together with our endocrine colleague and all that. Because again, you need to monitor because it also has side effects and all that. Yeah.
Another question, for patients with probable sarcopenia, besides nutritional advice and physical activity, should we straight away prescribe vitamin D and protein supplementation?
Okay. So I guess if we look at the treatment, algorithm just now, if we can, actually after we screen, if we think that they have probable sarcopenia, if we have the mean to check their muscle mass, I think go ahead and proceed and check to confirm the muscle, the low muscle mass. To confirm the diagnosis, okay, and then start the protein supplementation and all that. But I guess if we are in clinic kesihatan, the access to all this investigation is limited. And we have looked at other, blood parameters and all that to look for secondary causes. There's no obvious secondary causes or medication that may have caused, that sarcopenia. Then I think it's okay to start the protein supplementation. Vitamin D, however, is quite easily checked because actually a lot of labs can do vitamin D check. The cost, it's used to be 50 ringgit, but now with the inflation and US and all that, so now it's become like 90 ringgit plus. Okay, but it's something that we can check. So to me, with vitamin D, I think it's always good to have the baseline that we know that it's low to begin with, okay? Because there's no evidence to supplement vitamin D if it's not low. Yeah. But we also have to remember our population, definitely a lot in Malaysia is vitamin D deficient, okay? But it's always good, I think, if we have the opportunity to check the level pre-treatment, is good to have that practice too if we can. So my answer is, if possible, can get the baseline objective investigation so that we are sure what we are treating, and then start the treatment.
Regarding the protein supplementation, does it matter which type of protein?
Okay. This one, yeah, there's different type, right? Whey protein. Oh, sorry. This one, I probably sorry, I can't really sort of say it off offhand at the moment. But I don't know, Dr. Alan, you want to help me with that?
I think the issue is in our Asian diet, a lot of carbohydrates, but inadequate protein. Like the Chinese, they like to eat porridge, noodle, and a very little tiny protein in there, you know. So it's yeah. So I would actually educate the patient first. What is carbohydrate, what is protein, all that, and then tell them what is the requirement based on their weight. Okay. So a general requirement for an older person would be 1.2 grams per kilo per day in divided doses. Okay, so apparently there is a plateau. If you supplement too much at one sitting in one meal, so there is a maximum protein muscle synthesis around 0.4 grams per kilo per serving would be the optimum amount. So if you, let's say you give 0.5 grams per kilo, 0.6 gram, you will get the same muscle synthesis as 0.4. So that would be the I think there are many methods of protein. The whey protein, the casein protein, the soy protein. Okay. If you say that the soy protein is inferior, you look at Arnold Schwarzenegger, our Mr. Universe. He's a vegetarian and he could build his muscle to win the the Master Universe trophy by taking soy protein. So I think all the proteins are good. But of course, there are differences. Like whey protein, their biological value is higher. More percentage will be incorporated into the body. The absorption rate is fast. So, do you go to gym? Siti, do you go to gym?
You at home.
So, for gym, after their workout, there's a time frame, a window period where they want to hit the fast absorption protein to take advantage of the muscle synthesis that time. So they time the protein like within 1 hour after the gym. So I think that the whey protein or the fast protein will be the best that time. But of course, before even the gym, you need to take something, maybe a slow protein, otherwise you'll ping some or hypoglycemia. You know.
Yeah.
So
But I
it's
think another point to remember also, with sarcopenia, it's not because you have to supplement like protein, and the resistance exercise is important to bulk up that muscle. Because a lot of times, I think our older people generally, because they don't exercise much. So we say, they eat, so they tend to eat a lot, and they might gain weight because too much protein also can be converted to fat after that. But without the exercise, then we're not achieving that muscle mass that we want as well. Yeah, so that's another point to remember.
yeah. A very important point. Not only protein intake, but also resistance exercise. Resistance exercise. If you take protein a lot without resistance exercise, the muscle synthesis is transient. You lose it if you don't maintain it. So, any last burning question? We have 2 minutes more. Okay, there's one. Is there any resource that we can show our patients to show them the examples of resistance exercise?
Actually, there are a lot actually on internet that we can find on the internet. I don't have sort of any particular website to that I can recommend at the moment. But definitely, if we actually just Google it, this type of resistance exercise, but it would be good also. But I find also even with sarcopenia and all that, because in geriatrics we always work multidisciplinary. So, involving another, like for example, with physio and all that, again, they also can, tell the patient, what's the, type of resistance exercise that they can actually practice at home. And, how, use the band, for example, the elastic band. That's also another thing that they can use as resistance exercise. Yeah. So, and I find another thing is also sometimes our older patient also like to be involved in, with other than doctors. For for example, they like to share, if, they have appointment to see physio, actually they're quite, happy to see other people too, other than doctors. So I think, if we can involve, our, physiotherapists and all that, I think it would be a good thing also for the patient. Yeah.
So, okay, yeah, 4 p.m.
Okay.
So thank you very much for the enlightening talk and also the active participation from the floor.
Yes, thank you.
So, okay, any further questions, you can email Dr. Siti. Right. Thank you very much. Bye.
Okay, thank you. Bye-bye.
Thank you. Thank you, Dr. Ellen and Dr. Siti Nurbaya. See you next time.
See you.
Thank you, Dr. Siti. Thank you, Dr. Ellen. Thank you, Dr. Priscilla.